Good morning, everybody, or afternoon. I'd like to welcome you to Dental XP in my presentation, which will be implant positioning in the aesthetic zone. My name is Dr. Michael Sonic. I'm a periodontist here in Fairfield, Connecticut, in private practice, and one of the experts for Dental XP. I'd also like to thank our sponsor, Dentsply, for helping support this program. This afternoon, I'd like to take you through some of the things that I think are very important in terms of presenting implants and positioning them to get ideal aesthetics. Today, we are able to get implants to integrate. However, the requirement is that they be aesthetic as well. We as periodontists or as implant surgeons or oral surgeons or those placing implants have an ability to control the quality and quantity of bone by developing the site first before we go ahead and place our implant. And if you look at this triangle, which is the aesthetic hierarchy, at the base of this triangle is what we call site development. That occurs during extractions, it occurs at the time of bone grafting, it can occur at the time of implant placement with bone grafting, and that's where we have most control. As we move up the pyramid, the second aspect is implant placement. Implant placement, we have less control, but more control than we do in terms of the restoration. Placement of the implant is very important. Its requirement is that we have adequate bone to be able to place the implant in the ideal position. Soft tissue is also important, but we can't have good soft tissue unless we have proper implant placement and proper bone. And finally, we have the restoration. This triangle is from Dr. George Priest's article in Practical Periodontics and Aesthetic Dentistry that was published in 2005. In this case here, we see 5 implants that are positioned, and they're positioned inappropriately. And they're positioned where the bone is, not where they should be from an aesthetic point of view. You can see that they're all 325 millimeter implants, and the implants are far too apical, and they're also far too labial. So not only are they positioned poorly, there's not enough bone to position them in the right area. So yeah, the surgeon could have done a better job positioning them, but really they couldn't unless they had the bone. So if there's not enough bone, the right position to put your implants in an ideal restorative position, probably the implant procedure should be aborted, bone should be regenerated. One of the requirements for an ideal implant is to have adequate bone in a position not only so the implant can integrate, but adequate bone in a position so that the implants can be placed in an ideal position. So a good restorative position is dependent not only upon good bone quality and quantity, but adequate gingiva, which we need for ideal aesthetics. And the implant must be positioned in an ideal 3-dimensional position. Also, the timing of the implant is important. When do you place the implant? Do you place it at the time of extraction? Do you place it a few months after the extraction? Do you place it a few months after the extraction with bone grafting? A lot of things that come into terms. All of these things interplay with each other. Today, due to the limits of time, we're going to focus on one aspect, and that's just ideal implant positioning in the aesthetic zone. Now, the general concepts, besides having enough bone and gingiva, which I like to overgrow in timing, is the ideal position of the implant. So let's talk about the first aspect. Where do you place the implant in a mesial distal position? If you look at the implant success, there are 2 requirements that the implant must have if you are going to place it. First is that the implant must be stable, and second, as we discussed, is good restorative position. The implant stability is dependent upon bone quality and quantity. Restorative position is dependent upon not only the bone, but the gingiva, 3-dimensional position, and timing. And this we covered in an article published with Dr. Wong in 2007. Ideal positioning of the implant requires that it's placed proper for each tooth. In the aesthetic zone, when we're looking at teeth numbers 6 through 11, one of the things that comes to mind is the soft tissue position of the gingiva around the teeth. Oftentimes, I will draw a line from the canine to canine and see if the centrals lie upon that line. In this diagram from Claude Ruffenach's text, Fundamentals of Aesthetics, published by Quintessence close to 2 decades ago, he outlines how the canines and the central incisors should be on the same line, the same plane. If you look closely, you can see that the lateral incisors are about 1.5 millimeters to 2 millimeters beneath that plane. This is ideally how I like to set up the soft tissue when placing implants. This diagram is important because if we're going to be placing an implant, let's say to replace a central incisor, I want to place that implant so that when it emerges through the gingiva, okay, it comes through the gingiva in a position that is symmetrical with the contralateral central incisor and at about the same plane as the canines. The laterals, 2 millimeters more incisal. The second line that I look at is a vertical line drawn between, that shows where the height of contour is of teeth numbers 8 and 9. If you look at the vertical lines in this picture, they're slightly distal to the midline of the teeth. If you look at Dr. Chu's work or the work in Wheeler or from any denture aesthetic textbook, the center of the central is not in the same position of the gingival zenith. So when placing an implant, I try to place the implant slightly distal. The lateral incisors, the implant goes right in the middle of the tooth. So those are two other concepts to think about when placing implants is where do I place the implant in a mesial distal position. So for centrals, just to review, I like to place the implant slightly distal to pick up the height of contour of the parabolic arch of the gingiva or the gingival zenith. For lateral incisors, I like to place the implant directly in the midline of the tooth. I also like to have 2 millimeters between implants and teeth or bone, and 3 to 4 millimeters between adjacent implants. However, I try to avoid placing implants adjacent to each other in the aesthetic zone, because as the implants get too close, you start to lose bone. And as you lose bone, as we see with our aesthetic triangle that I showed you by Dr. Priest, we not only lose the bone, but we lose the soft tissue. Or we either get a dark triangle between teeth or a longer contact point. In this patient who was treated in 1990, close to 20 years ago, one of the first single tooth implants that I placed, we removed her central incisor, which had a horizontal root fracture, and let the area heal. In her case, we waited a full year because she got pregnant after the extraction. No bone grafting was done, which is not the way we do things today, but she still healed very well. This next line that you see comes right directly through the gingival zenith. The gingival zenith is slightly distal, and we reviewed this case in 2005 in an article published in Inside Dentistry. The implant was placed, and you notice that where it is placed corresponds to the white line, which is slightly distal to the midline. So when I place a central incisor, there are two lines that I look at. I look at first the center of the tooth, which is depicted by the green line over the x-ray. The second line that I look like is the purple line, which is slightly distal. The implant is aligned with the purple line, which is slightly distal, to pick up that gingival height of contour. If the implant is placed on the green line, what you'll get is a very symmetrical central incisor, which is not what a central incisor looks like. A central incisor is asymmetrical. The gingival zenith slightly distal. In this diagram or photograph taken 15 years postoperatively, you can see that the gingival zeniths are slightly distal and that the soft tissue is coincident with both the natural tooth on the left side, tooth number 8, and the crown on the right side, crown. And this is at 15 years. We have good tissue stability because it's a thick biotype and we have good bone around the implant. Oftentimes, we have very thin periodontium, as you can see in this case. Tooth number 8 is a crown that's failing due to endodontic failure and failing apicoectomy. You can see the apicoectomy scar, the amalgam tattoo, and the very thinness of the periodontium. This is what we could call a thin case, as defined by Dr. Arnie Weisgold at the University of Pennsylvania years ago. Can we predictably turn a thin case into a thick case? Now, is that possible? Well, in this case, it's sort of necessary if we're going to place an implant, have it in an ideal position, and prevent recession. Here's the implant placed in the area of tooth number 8 at about 4 years post-surgically, and you can see that the gingival zenith is slightly distal. The amalgam tattoo is gone because not only was bone grafting done, gingival grafting was done, but most importantly, the implant was placed slightly distal to pick up that gingival height of contour. So, how can we predictably maintain papilla between implants? What's necessary? Well, what's necessary to maintain papilla are 4 things. Number 1, we have to have adequate bone. 2, we have to have adequate connective tissue. Also, the contact point And the proximal bone support of the adjacent crowns is very important. As described by Tarnow and Wallace and Cho and others at NYU, the distance from the implant, the bone around the implant, from the adjacent teeth is also important. As that implant gets too close to the adjacent teeth, oftentimes we lose bone. Bottom line is, you need bone to support the papilla if you're going to have an aesthetic result. Excuse me. That's critical if we're going to get an ideal result for cosmetic areas. So when I would look at cases, one of the first things I look at is how much bone do we have around that implant. Let's first of all talk about the distance of the implant from the adjacent teeth. In Tarnow's seminal article published in 1992, close to 18 years ago, he measured the distance from contact point of the bone to teeth. And what he found that if the contact point from bone to teeth was 5 millimeters or less, a papilla was present almost all the time. As the distance from bone to contact point increased, there was a less of a chance of developing a papilla. Choke in 2001 looked at the distance of contact point to bone with implants. And in this case, we have an implant next to a natural tooth. We found something very similar. When you have bone next to an implant along a natural tooth, the position of the bone on the natural tooth will help determine whether a papilla will be present. If the position of the bone on the natural tooth next to the implant to the contact point between the implant and the natural tooth is 5 millimeters or less, a papilla was present almost 100% of the time. In Nick Ellion's article, published in Practical Periodontics and Aesthetic Dentistry, he drew very diagrammatically the position of the biologic width. And in this case, which I'll show you, shows a natural tooth in the area of tooth number 8, which is going to be removed and you're going to have an implant placed. Take a look at the papilla on tooth number 8, both mesially and distally. It's there. It's there because you have bone around the natural tooth. The biologic width is 3 millimeters. However, interproximally, the papilla is 5 millimeters from the bone. How can this be? Well, the biologic width is 3 millimeters, but you also have the interdental papilla and the coal area, the soft tissue that is really not supported by bone, but that peak of soft tissue between teeth that gives you the papilla. That is usually 5 millimeters from contact point to bone on natural teeth. And you can see it as circled by the white circle to your right. If we take an implant, and this is the same case with an implant in place, you can see that we have papilla. The papilla is still present. However, it's the bone, not around the implant, but around the teeth adjacent to the implant that supports the papilla. That's where the biologic width is formed. The implant is placed beneath the crest of bone, and we've lost bone around the implant. In the aesthetic zone, we oftentimes place the implant subcrestally so that we can develop an aesthetic restoration and develop proper emergence profile. When the implant is placed beneath the crest of bone, you lose some bone around the implant. However, if you keep the implant 2 millimeters from teeth that do have adequate bone, that bone on the tooth will support the soft tissue that will give you your papilla around the implant. In summary, it's the bone on the natural tooth next to the implant, adjacent to your implant site, that is critical to support the soft tissue to develop your papilla. And if we look at the same case with the natural tooth and the x-ray of the natural tooth, followed by the extraction and the implant placement, you can see that an implant adjacent to a healthy dentition doesn't affect the interdental papilla because of the supracrestal position of the biological width on the teeth. As you move the tooth closer to a tooth, you'll lose bone because of the biologic width that forms horizontally around the implant. As the implant is moved closer to the tooth, bone is lost next to the tooth. Therefore, don't place the implants too close to teeth. Our recommendation is that you keep them 2 millimeters away. This diagram, taken from Tarnow's article, 2000, he recommended keeping the implant 1.5 millimeters from teeth because of the horizontal relationship to the biologic width. Our recommendation is that you keep it 2 millimeters to give yourself another ½ millimeter of wiggle room. It's very hard to work within a ½ millimeter. So for a single tooth implant to replace a central incisor, a recommendation is that you have 2 millimeters on either side of the implant. If you're going to be placing a 4 millimeter implant, I would recommend a 8 millimeter space to place that implant. If you're placing a 325 millimeter implant, I'd recommend a 7¼ millimeter space before placing that implant. So keep the implant at least 1.5 millimeters from teeth, but my recommendation is 2. Now, the implant position also depends upon the coronal level of the bone, as pointed out by Grunder and Rosas Capelli in International Journal of Paradox Restorative Dentistry in 2005. In this case, we have an abscess tooth due to internal and external root resorption, as you can see. And when this tooth is removed, you're going to lose bone. Well, the bone has already been lost, as you can see on the distal aspect of the central incisor. So when that bone is lost, that tooth is removed, and that infection, I'll go back to one more, you can see there's an infection. It's the suppuration and the pus in that area that is supporting the papilla. The papilla is not supported by bone. So when that tooth is removed, that infection is going to resolve, and this is what's going to happen 2 months post-extraction. You're going to lose soft tissue on the mesial of tooth number 10 adjacent to the infection. Point being, inform your patients that they may lose soft tissue because the bone has already been lost before you extract the tooth. If the patient is not informed before that tooth is extracted, the patient may be upset with you. You extracted a tooth and caused soft tissue loss. Could this have been prevented? Probably not, because the bone was already lost. In this case, which was done close to 15 years ago, we placed one of the early hybrid external hex implants in place made by 3i. The implant is placed, and you can see on the mesial of tooth number 7, we have 3 to 4 millimeters of bone loss. Look at the distance of the CEJ at tooth 7 from the rest of the bone. Can we regenerate that bone? Not predictable. So we're going to be short in our papilla. The patient should be informed in advance. We still have threads exposed. About 7 threads are exposed on that implant. And we'll take autogenous bone. We'll pack that over the implant. And utilizing the technology that I had 15 years ago, we took a Gore-Tex membrane and placed it over it. Oftentimes, we used to use these traps, bone traps, to suck bone out when there was preparation of the osteotomy side. I recommend that you don't use these today because they do cause contamination of the bone because you're sucking in saliva. So a recommendation, if you're using these, probably put those away and harvest your bone with maybe a safe scraper or something like this where you can take some autogenous bone with sort of this reverse action. You pull up little flakes of the bone. You can do it this way, or with drilling at slow speed in your osteotomy sites, or with curettes or back action chivels, etc. So the autogenous bone was packed superior to the implant. The Gore-Tex membrane was placed. It was stabilized with 2 titanium tacks labially, and we stabilized it palatally with 1 suture. Notice that the Gore-Tex is cut back 1.5 millimeters from the teeth so as not to cause any contamination of the membrane. Today, we'd most likely use resorbable membranes in this case, but the principles are the same. You want to stabilize the membrane as best possible, create a space beneath the membrane with your graft, and cut your membrane shy of the adjacent teeth. 6 months later, the area was exposed and the membrane was removed. You can see it's still present. The glistening white is the membrane. The 2 tacks are there. The tacks must be removed. And temporary healing abutment is placed. The temporary healing abutment is placed on for 2 to 4 weeks. Then the patient is provisionalized. In our practice, I recommend that the provisionalization be done first after the soft tissue has healed. So I like the soft tissue to heal for about 3 to 4 weeks before we provisionalize. It gives me a little bit more control in growing soft tissue. So the patient, in about 3 weeks, is sent back to the dentist, and then the dentist has placed a provisional on tooth number 9, where the implant is. And you can see that we have a lack of papilla between tooth number 9 and 10. At 6 weeks, the papilla is starting to come back, but I don't think it's going to come back. It's just too much bone loss. So I asked the dentist to add some bonding restoration to the mesial of tooth number 7. And at about 8 weeks, soft tissue is coming back, and I don't think we're going to get much more. We may get a little bit of maturation of the papilla, between 9 and 10, but not much more. At this point in time, we allowed her to heal up until 3 months, and then we restored her. A single crown on the implant and a veneer on tooth number 10. So, provisional restoration, in this case, helped to guide the soft tissue. Excuse me. One of the things that I do recommend is that we leave the patient in a provisional in the aesthetic area for 3 months before we go to the final restoration. Some people can't predict exactly where the provisional should be, where the final restoration should be. My recommendation is to work it out in the provisional like a dress rehearsal, so when we go to the final, we have something that's predictable. Here's the final restoration. And it looks good, but we lost the papilla between tooth number 9 and 10. And if we look at the x-ray of the implant, we can see why. We've lost bone on the mesial of tooth number 10, lateral incisor. And if we take the x-ray away, you can see there's the bone line. And there's really two lines that you look at. There's a papillary line and a bone line. And they're coincident. They follow each other. The soft tissue follows the bone. And as David Garber says, the bone sets the tone, but the tissue is the issue. Without bone, you're not going to get the soft tissue. Now, how could we have gotten bone here? Could we have grafted it? I don't think so. What else could we have done? Well, we could have erupted tooth number 10, pulled the bone down with that area, and then created the crown and perhaps endodontics on tooth number 10. Here's where we started, and here's where we ended. An acceptable restoration, one that the patient's happy with, but a compromised restoration because we have a little less bone. Nothing was done wrong as long as the patient is informed before you begin the case. Now, in terms of buccal palatal positioning, I like to keep the implant slightly palatal to the incisal lysis angle for cemented restorations and through the cingulum for screw-retained restorations. There's a movement foot today to become a little bit more screw-retained in our final restorations to prevent cement from going subgingivally. I like that, but the implants must be positioned ideally, especially in the aesthetic zone for that. I particularly like using screw-retained provisionals for my temporary restorations because it keeps the cement out and allows us to guide the soft tissue more predictably because we can screw-retain a provisional that may be a little larger than the space beneath the gingiva. Therefore, that provisional can be screwed down, and that provisional can help shape or groom the soft tissue. Avoid angling the implants too far labially because you're going to cause recession. This patient I treated, in 1990. We took out a failing apicoectomy, treated tooth, and his lack of labial plate. We ended up bone grafting it and avoiding the implant procedure and going back a few weeks later, actually about 6 months later, to place the implant. Papilla-sparing incision was done, which I don't agree with, but this was done in 1990. And the incision, as you can see, is placed too far to the labial. Because of the position of that incision, it is impossible to place the implant in an ideal position. Matter of fact, I even have a stent that I made, guiding the implant through the labial plate, assuring that the implant won't be in the right position. Was this our goal? Matter of fact, sadly I say it was. In 1990, the goal was to place the implant slightly to the labial, because that's what the manufacturers of this implant recommended to do at that time. And I did this case with the prosthodontist in the room, and we photographed it in the wrong position. I thought that this was the right position. Here's the implant with the temporary healing abutment, and you can see that the implant is not palatal to the line angle, but buccal to the line angles. Too far buccal, and we ended up causing recession and having a longer tooth. Now, it worked out okay because he didn't have a high smile line, but this implant was poorly positioned. Because of its poor position, we had a little bit of labial recession. Here's how the patient presented to our office, and here's the patient at 10 years later with some recession. The lips covered a little bit, but it's still not ideally placed.